Generally, when we talk about medical diagnostics, it's a big, we know it's central role that it plays in medical practice. And as laboratorians, we always pride ourselves by the fact that we say 70% of medical decisions are based on what we do, and it's variable. But like Mr. Kesa has just mentioned, accessibility to medical diagnostic, and sometimes when you talk about medical diagnostics, not only laboratory diagnosis, we extend even to the imaging side of things. But it's stunning findings, like Mr. Wekesa has alluded to, that about half of the global population cannot access diagnostics. And we know in Africa about 60% rural, is a rural population, and they grapple with a lot of things, especially low infrastructure and accessibility. And they have to grapple with long journeys to access diagnostic services. And AFIDEP in 2023 did a study, and they saw that on average, a Kenyan would travel 24 kilometers just to access a diagnostic service. And it made me think, for example, in this Nairobi, and this is a city, and you live in the Nairobi metropolis. And just an example is if you live in Juja and you are accessing a test in Kenyatta National Hospital, you'll have to travel more than 24 kilometers to get that service. So that's how big, and that is when we are in a city. What about if we move now to the periphery of this country? How tedious could these journeys be? And if we leave out HIV and malaria, in low middle income countries, only less than 20% of the population is able to access diagnostic services. So these are very serious statistics that we have to look at. But what do we do as we try to fill these gaps? There are three factors that helps to fill these gaps, and one of them are the global health priorities. Mr. Wekesa has really done a lot of justice in the first one, that is universal health coverage. We also have the AMR, antimicrobial resistance, and we know where we come in and how it talks about testing and the importance of testings in trying to fight AMR. Global health security is a global priority. We all know the current mpox and the surveillance that is there. We need testing. We all remember that outbreaks will always come, and we need testing at the point of exits and at the point of entry so that we can protect the global. We also have the essential diagnostic list, as Wekesa has alluded to. And most importantly, when I was preparing to this, I also realized that Kenya signed its own Kenya essential diagnostic list in 2023. I would invite you to look at that document. It is very good. It tells you at which level what should be available in that level of a facility. And then, of course, we can never forget the lessons that we learned from the COVID-19 and how best it shows how a laboratory comes in. And the solution to this, of course, we will always talk about point of care. And the adoption of point of care is real in Africa. If you look at the statistics, the market survey shows you that the compounded annual growth for point of care is about 5.7 and is estimated to reach 816.12 million by the year 2028. And the catalyst to this growth, of course, is the incidence of non-communicable diseases, especially diabetes and cardiovascular diseases and cancer. And also the emerging point of care diagnostic technologies, like you've just seen what has been presented before I came on stage. But we still have inhibitors to this growth. We still have the issue of cost. Cost is a huge discussion in terms of point of care. And we also have regulation, both in country and in institutions, we still have regulations. But for us to achieve the benefits of point of care, there are things that we must meet as an ideal point of care. And there are some of the requirements that you have to meet when you're having a point of care. First of all is the organizational responsibilities and authorities in terms of point of care operations. Then we have documented policies and procedures. They have to be documented. And of course, in the morning, we looked at the new authority coming in and talking about the documentation of all your procedures that you need to do. Then we have the key operator training and competency, because results from a point of care are as good as the operator's training and competency. We have also appropriate results management. How are the results going to be managed? Because as we know, point of care testing is complex in a way, because you have multiple users using multiple equipments in multiple sites. So how are you going to manage the results that come from all these equipments that you, or gadgets that you have? The quality assurance systems, of course, we cannot overemphasize on it. And then, of course, M&D, how do we monitor? Basically, these are about audits. So in view of these factors, the AFCC Committee on Point of Care Testing did a survey. And this survey mainly was just to look at what is the overall practice in the African setting, to look at how generally point of care is practiced. And we had a total of 176 respondents from 13 countries. Kenya had the highest at 34% with the other countries. Interestingly, again, from these participants is that most of the countries that participated are members of the AFCC. As you can see, some in the Southeast and Northern Africa, but we didn't cover the range. But it gives us a picture on how practices are. We would have wished to see that map more participants from other countries. But in terms of demographics of the participants, majority had a bachelor's degree, and medical laboratory technologists were the highest at 54%, and most of them, over 57%, had more than 10 years of experience in practice. If we look at the facilities and practices, 68% said they were practicing point of care testing on a daily basis. In terms of healthcare facilities, the highest were the government tertiary institutions with 38%. When we looked at training and competency, this was very interesting, because 47.7% informed that they had never had a formal training and certification, yet they were performing point of care testing. And when we look at the responsibility of trainings, 44% said the responsibility lies with the laboratory or pathology department. But what was interesting to me is that 11% said they were self-training themselves using manufacturer inserts. When we asked about the knowledge on the QC requirements in terms of point of care, 87 said they were aware. But when we asked about the QC frequency, it was varied. The highest said it was occasional and it was not consistent in their practice. When we asked a very important question about results reporting and connectivity of the point of care gadgets, 60% reports are manual, and that translates also to ordering of results. I don't know if ordering for point of care, most of the time I feel is more verbal than the other way that we do laboratory requests. But the reporting 60% is still manual, and connectivity, 68% of POCT gadgets are not connected. And we know with connectivity, you can manage a lot of things with connectivity in terms of quality, in terms of managing cost, in terms of managing test. But as you can see, there's a very huge gap in terms of connectivity on point of care. When we asked about the governance, where do POCT concerns are reported, again, it's the laboratory or the pathology department. And when we asked about another important aspect of managing point of care, that is the multi or interdisciplinary POCT committee in the institutions, Only 28% of the participants said they had a multidisciplinary POCT committee, and 56% said they didn't have, and 14% were not sure. And just by show of hands, probably I can ask the audience, how many are aware of a multidisciplinary committee in an institution in terms of point of care testing, just by show of hands? Yes, then this survey would really tally with us, because this committee is very important in the management of a POCT program. When we asked about policies and procedures, 58% said policies and procedures were available, but the accessibility in a scale of 1 to 5 was still an issue, because only 25% said the policies were easily accessible to them. So what were the key learning points that we learned from this? POCT is widely available. That one was what we saw. Most of the institutions have policies and procedures for POCT, but the accessibility still becomes an issue. Training of POCT operators is not structured in most institutions. So how we train is not structured. Either the pathology people will train you, or people will assume that if you have a kit insert, you are able to train yourself because of the simplicity of the gadgets that you have. The QC requirements are widely embraced, and POCT results are still being manually recorded with very minimal connectivity. Multidisciplinary POCT committees is still a very new concept in majority of our the respondents of these studies. And the stakeholders and other healthcare providers in performing POCT, we actually don't know their views, because our study majority were laboratory-based professionals. We had only 2 non-laboratory reporting responding. Just as I come to the end of my presentation, I would just like to highlight a few things about the associations that we associate with. At the global area, we associate with the AFCC, that is International Federation of Clinical Chemists and Laboratory Medicine, which works through regional federations. And our regional federation is the AFCC, where we did this study. But at the national level, we have our national association, which is Clinical Chemist Association, which now completes the chain of the associations in terms of clinical chemistry practice. And I would invite you, in your free time, you can visit this website, ccak.co.ke. We also have upcoming events in November. If you visit that site, you'll be able to see. In page 25 also of your booklet, there's a QR code. You can scan that QR code, and it will send you directly to our page where you can interact more. Thank you so much for your time.